I have the distinct pleasure of inviting a very good friend and collaborator on a few past projects, Lucia Rivera, who has done phenomenal work in cerebral oximetry and other non-invasive paradigms in mechanical circulatory support. And today we'll be telling us a little bit about DCDs, both in cardiac arrest as well as cardiogenic shock with MCS.
Thank you, Dr. Sarwal, for that amazing introduction and for inviting me to be here. It's such an honor. I'm going to share my screen. Can you guys see it?
Yes.
Perfect. So the sun is just rising in California. Good afternoon to our friends in Europe. Today, we're going to be talking about a very interesting topic that we don't think a lot about, which is how is my TCD going to change depending on which mechanical circulatory device my patient is on. So I have nothing to disclose. We're also going to be talking about the understanding of the physiological changes in these patients, as well as reviewing these major studies that have been done in this population. And as everybody has done already, reviewing the expert consensus statements. So when we talk about mechanical circulatory support, we refer to these devices that have been designed to assist or replace the function of the heart in these patients that have a severe cardiogenic failure that is refractory to medical treatment. And in those, you guys can see we include the intra-aortic balloon pump, the Impella, the LVADs, patients on VA ECMO, that can be all used as a bridge to transplant or as a destination therapy. And the important thing to know here is that these patients are living without a pulse. And you guys can see here this nice waveform from an arterial line where you see the systolic, the diastolic peak, and the nice pulse pressure that we all know we have physiologically. But these patients don't. And this is despite they continue to have their normal cardiovascular reflexes that depend on this pulsatile flow. These are the most common LVADs that are being used lately. And as you guys can see here, there is very little pulsatility with the HeartMate 2. And HeartMate 3 is a little bit better. However, it does not really restore the physiological pulse. How is that going to affect our transcranial Doppler? So transcranial Doppler can tell us a lot about pulsatility, as we have been talking during this webinar. And as you guys can expect, in patients with VA ECMO, there is no pulsatility, at least in the beginning. And these patients have a continuous flow without any clear systolic peaks. Patients with LVADs, as we said previously, they are going to have a little bit of pulsatility that is going to be also be present in transcranial Doppler. And what about Impella? They do have a distinct pulsatile waveform compared to the other types. And with patients with intra-aortic balloon pump, they do have a pronounced diastolic upstroke, as you guys can see here, that is not seen in any other device. And this is a patient that had total artificial heart. And you guys can see that the waveform almost resembles the hemodynamics of an unassisted patient. And all these changes in the fact that these patients live without a pulse or little pulsatility carries a lot of problems in terms of bleeding. So these patients are going to have a lot of GI bleed. They are going to have epistaxis, and they are also going to have, unfortunately, a really high rate of stroke. And it has been described up to 30% at 2 years, which is really not acceptable. We have talked a lot already about pulsatility index. I'm not going to get into this because it was previously discussed and we are running short of time. However, in patients that are on ECMO, you do have to think about how your end tidal and hypercapnia is going to change your pulsatility index. So as you guys can see here, this is a study in animals where they increase the end tidal CO2, and you see how the pulsatility index decreases increases as your cerebrovascular resistance decreases. However, it's not gonna always follow the cerebrovascular resistance when your autoregulatory status has been compromised, and if your CPP is very low, you're gonna see an increase in your pulsatility index. So far up to now, we have described the physiological changes that we typically see in these patients. One is that the pulse pressure is reduced. Two is that they have an abnormal waveform, TCD waveform. And three is that the pulsatility index is also going to vary, not only related to the intracranial pressure, as we have discussed earlier today, but also related to hypercapnia and your CPP. The clinical applications of transcranial Doppler after cardiac arrest are very similar to the ones that we have discussed through the webinar, right? Documentation of the circle of Willis, identification of relative hypo and hyperperfusion, as well as detection of cerebral emboli. However, it is also very important to use it as a tool for therapy, as it has already been discussed, to evaluate the autoregulation status and to define the optimal blood pressure. Before we move to autoregulation in cardiac arrest, I want to show you this study that looked at the cerebral blood flow velocities in pediatric patients while they were on VA ECMO, and notice that they were different. So the systolic velocity, as well as the mean velocity and the PI, were significantly lower in the first few days. Which makes sense because these patients have severe myocardial depression in the first few days, and that the diastolic velocity was preserved, as it is expected, because the VA ECMO flow is continuous and non-pulsatile. There is a more recent study done in adults from the Hopkins group looking at what are the normal velocities or the expected velocities to be expecting for these patients on VA ECMO. And in this study, they compare VV and VA. And what they saw, before I go to the results, I noticed that this is a little bit different in terms of the methods from the prior study, where they monitor patients throughout their hospital stay. So most patients were in the first 10 days, however, they were not in the hyperacute period. So in this study, they found that there was no significant difference between the velocities, except for the posterior circulation. However, when they analyzed that per cannulation site, they found that it was only different in the when they were cannulated peripherally versus centrally. The findings with the pulsatility index were very interesting. So in the patients where they were able to find pulsatility index, there was no significant differences between the numbers. However, only in half of patients with on VI ECMO, they were able to isolate the pulsatility index, which is very different to the 95% on VV ECMO. And some of the hemodynamic variables that influence this, as expected, it was the pulse pressure, right? The presence of a pulsatility, as well as a higher systolic blood pressure and diastolic blood pressure. The most interesting finding was that the absence of pulsatility on the transcranial Doppler was most frequently associated with intracerebral hemorrhage, so 14 versus 1%. And then these patients that had absent pulsatility also had more events of bleeding while they were on ECMO. And this is just a picture showing you little pulsatility to non-present, how it was restored after total artificial heart to very close to normal looking pulsatility. So what is important to know in cardiac arrest, and the guidelines tell us, is that we should consider advanced serial monitoring. And if you don't have it, maybe you should shoot for a higher MAP of more than 80 millimeters of mercury. However, if you do have advanced multimodal monitoring, you should use any of the different tools, in which case you can use transcranial Doppler to maintain a MAP near to the predicted optimal MAP. And the reason why is that, as this study has shown us, this study, by the way, was done on with transcranial Doppler, the half of the patients had impaired autoregulation. And the ones that had preserved autoregulation had a curve shifted towards the right, meaning that the majority of patients after cardiac arrest had absent autoregulation, or the autoregulation is shifted to the right, which makes it a really good population to actually individualize blood pressure parameters. And as shown here, you can do this at the bedside with multimodal monitoring using transcranial Doppler and show calculating the optimal CPP, or optimal mean arterial blood pressure. Some of the research gaps are to validate the pulsatility index and the other parts of the transcranial Doppler as a marker for to detect acute brain injury in patients that have mechanical circulatory support. I would love to see a study where we use daily TCDs to trend as a trend, as we see do it in patients with aneurysmal subarach, to screen for acute brain injury. We are also lacking studies looking at optimal map determination with transcranial Doppler in patients on VA ECMO to optimize their brain perfusion. And also, we need a lot more studies to look at primary and secondary stroke prevention in patients with mechanical circulatory support. The really high rate of up to 30% is unacceptable. And we need to strengthening more the knowledge of the brain-heart connection. And we are actually working on this. We are editing a book on neurocardiology, so stay tuned for 2026. And with that, I welcome any questions. Thank you so much for the invitation.